Welcome my dear students to the session of anatomy doubts. Today we will be clearing some of the doubts. Okay. Coming to the question number 1. The facial cleft seen below occurs due to the failure of fusion of. Okay. So the options given here are median nasal process and maxillary process, median and lateral nasal process, maxillary and lateral nasal process, median and lateral nasal process with maxillary process. Okay. So the student have confusion between the option C and D. Okay. So the answer here is the maxillary and lateral nasal process. See, it is an oblique facial cleft. Okay. So it is extending from the eye to the mouth. It is a oblique facial cleft. So look at this image. So this is the maxillary process. This maxillary process grows medially below to fuse with the lateral nasal process, and further it grows and fuse with the median nasal process. Okay. So if this maxillary process fails to fuse with the lateral nasal process, what results is the oblique facial cleft. Okay. So if the maxillary process fails to fuse with the median nasal process, means it results in cleft lip. Okay. So you could see this, there is a swellings of lateral nasal and median nasal process. Okay. Between that is the nasal pit. Okay. The nasal pit will be getting separated from this, okay, by the growth of the maxillary process. Okay. So what is the main feature of this oblique facial cleft is the absence of the nasolacrimal duct. Hope it is clear. You could see it is extending from the median angle of the eye to the mouth. Okay. The oblique facial cleft, which is the failure of fusion of the maxillary and lateral nasal process. The cleft runs from the medial angle of the eye to the mouth. Nasolacrimal duct is not formed in this. Okay. Coming to the next question, circumvallate papilla are supplied by. Okay. So options are chordae tympani, glossopharyngeal, vagus and lingual. So look at this image. So the tongue has general sensation, taste sensation and the motor supply also. Okay. So the general sensation for the anterior 2/3 of the tongues, okay, except the circumvallate papilla. You have to accept the circumvallate papilla when you consider the anterior 2/3 of the tongue, because circumvallate papilla alone is supplied by the glossopharyngeal nerve along with the posterior 1/3. Okay. So other parts of the anterior 2/3 is supplied by the lingual nerve. General sensation is lingual nerve and the taste sensation is chordae tympani. For the posterior 1/3, along with the circumvallate, the sensation, general sensation is by glossopharyngeal, taste sensation is also by glossopharyngeal. Posterior most, general sensation and taste sensation is by vagus nerve. Okay. All the muscles is supplied by hypoglossal nerve except palatoglossus, which is supplied by vagoaccessory complex. Okay. Hope it is clear. So the answer here is the glossopharyngeal nerve. Coming to the next question. So main motor supply to pharynx is, student have a confusion between vagus and accessory. It is a quite confusing question. So look at this image. Okay. So it is a pharyngeal plexus. So pharyngeal plexus is formed by three things. One is the pharyngeal branch of the glossopharyngeal nerve, pharyngeal branch of the vagus nerve and pharyngeal branch of the superior cervical sympathetic ganglion. Okay. These three forms the plexus over the middle constrictor muscles and innervates the pharynx. Okay. So now coming to the next diagram. So see, all the muscles of the pharynx is innervated by cranial root of the accessory nerve through vagus except stylopharyngeus, which is by glossopharyngeal nerve, 9th nerve. Okay. So see, the pharyngeal plexus is formed by vagus, pharyngeal branch of the vagus. See the motor fibers, but the motor fibers are arising from 11th nerve. So the motor fibers, the red fibers, okay, the red fibers which goes from the 11th nerve and goes via the 10th nerve to the pharynx. Okay. So you can choose accessory nerve. So the main motor supply to pharynx is accessory nerve. So the next question, the site of schwannoma of 8th cranial nerve is, Okay, the answer here is the intracanalicular. Okay, so the site, this is also called as schwannoma of the 8th cranial nerve is also called as aquatic neuroma or vestibular neuroma. Okay, it is a slow growing benign tumor. Okay, so look at this notes taken from the article. So it is the common schwannoma. It consists of 90% of schwannoma arising from the cranial nerve. So the common is the vestibulocochlear nerve. Okay, the common site is the intracanalicular. That means it is the internal aquatic meatus. Okay, most common is the vestibular portion. So histologically, what you can see in schwannomas? So Antony A, Antony B, verrucae bodies. Okay, this you will read in oral pathology. Okay, so the most common is the 8th nerve, and the most common site is internal aquatic meatus. Okay, it is intracanalicular. So which cranial nerve underlies the facial colliculus, and what is facial colliculus? This is the doubt asked by one of the student. So the facial colliculus is an elevation in the floor of the 4th ventricle in the pons. Okay, it is in the pons. Okay, underneath that lies the nucleus of the abducens nerves and the facial nerve, which loops around it. The facial nerve loops around the nucleus of the abducens nerve. Okay, look at this image. Okay, so this is the 4th ventricle, rhomboidal shape. The facial colliculus is the elevation in the medial side. Okay, elevation in the medial side is the facial colliculus. Beneath the facial colliculus, you can see a abducens nerve nucleus, red color, the abducens nerve nucleus, and the looping around, the blue color, right? This is the facial nerve looping around this. Okay, so hope you understand this. So next question, root value of the phrenic nerve. It's a straightforward question. It is C3, C4 and C5. So the root value means which branches, this nerve is contributed by which spinal root. Okay, this is called the root of the phrenic nerve. See, the phrenic nerve is the contribution are coming from C5 and C4, mainly from C4 and C3. These three things gives contribution to the phrenic nerve. Phrenic nerve is very important supply for the diaphragm. Okay, the all other what you are seeing is the cervical plexus. Okay, these are the branches of the cervical plexus, the supraclavicular, greater auricular, lesser occipital, transverse cervical, and the ansa cervicalis. Very important, ansa cervicalis. So one of the thing is C1 through hypoglossal nerve to thyroid genioid. Okay, thyroid genioid alone is supplied by C1 through hypoglossal nerve. Okay, so you could see the C1 to C4 is by cervical plexus. C3, C4, C5 contributes to the phrenic nerve. So next question, not understanding the concepts of Savant's muscle and ridge. Savant's muscle is formed by palatopharyngeus. Okay, so the palatopharyngeus is also called as Savant's muscle. Palatopharyngeus and superior constrictor forms the ridge. What is it? Okay, look at this. Okay, you could see the muscles of the pharynx, superior constrictor, middle constrictor and inferior constrictor, the circular muscles. The longitudinal muscles, salpingopharyngeus, palatopharyngeus, stylopharyngeus. Okay, only the stylopharyngeus alone is supplied by glossopharyngeal nerve. Others are cranial root through the accessory nerve. Okay, so what is the Savant's ridges? This is the mucosal ridge. Okay, which is present in the posterior part of the nasopharynx. Where? It is in the posterior part of the nasopharynx. The upper fibers of the palatopharyngeus, okay, circularly runs deep to the mucosa to form a sphincter, which is internal to the superior constrictor. Okay, so when it contracts, it forms a ridge along with the superior constrictor. Okay, so when the soft palate elevates, it comes in contact with the ridge and it closes the isthmus, nasopharyngeal isthmus. Okay, so the communication between the oral cavity and the nasopharynx, okay, oropharynx and the nasopharynx will be closed by this ridge and the elevation of the soft palate. Just look at this image, you could see the nasopharynx, the nasopharynx and the oropharynx is communicated by pharyngeal isthmus, right? This isthmus is closed by elevation of the soft palate over this ridge, which is called Savant's ridge. Okay, so the food which you are swallowing will not enter into the nasopharynx, it will go into the oropharynx and the laryngopharynx. Okay, so these are the some important notes of pharynx. So in the nasopharynx, you have seen The posterior wall contains Savant's ridge, okay, so which is important for closing the nasopharyngeal isthmus, okay. So in the lateral wall you have opening of the auditory tube and the fossa of Rosenmuller, which is also called lateral recess or pharyngeal recess. The fossa of Rosenmuller is the common site of origin of nasopharyngeal carcinoma, okay. In oropharynx, in the lateral wall you can see a palatine tonsil. In the laryngopharynx you can see a pyriform fossa in the lateral wall, common for foreign body obstruction. Okay, what is the clinical significance is when you are removing the foreign body, okay, there is a risk of injury to the internal laryngeal nerve, which lies just deep to the mucosa of the pyriform fossa, okay, which is internal laryngeal nerve. What is Killian's dehiscence? So Killian's dehiscence is the like thin sheet of the thyropharyngeus on the posterior wall of the laryngopharynx, okay, so which may gives rise to a pharyngeal diverticulum. So in the next question, the second stage of the deglutition is characterized by. I think the question should have asked like the second stage of deglutition is characterized by all except. Okay. So the second stage of deglutition, in this second stage elevation of larynx happens, momentary apnea happens, there is a relaxation of the pharyngoesophageal sphincter. This is the upper esophageal sphincter. There is a relaxation, all these things happens. But contraction of the pharyngeal constrictor happens, not the relaxation, okay. So look at this diagram. The oral phase, which is the voluntary phase, where the tongue elevates and propels the bolus to the pharynx. It's a very important feature of the oral phase, okay, which is voluntary. Okay, then the involuntary phase, the pharyngeal and the esophageal phase comes, where soft palate elevates to seal nasopharynx. Okay, when the soft palate elevates, it goes and touches the Savant's ridge, okay, last slide we have seen Savant's ridge, so that it seals the nasopharynx and the larynx elevate. One of the important scenario happens in the pharyngeal phases, larynx elevates and the epiglottis closes the airway so that respiration stops momentarily and the pharynx contracts and the upper esophageal sphincter relaxes. So the bolus pushed into the esophagus. In the esophagus, peristalsis happens so that it reaches the stomach, okay. So these are the stages of the deglutition. So the posterior belly of digastric is especially active during, okay. So the answer is swallowing and chewing. So you can exclude smiling and frowning, which is the action of the facial muscles, not the digastric. Digastric is the supraoioid muscle, okay, which has its function, okay. So digastric muscle, what function it has? So look at this, digastric has depression of the mandible, okay, it depresses the mandible. What muscle of mastication, primary muscle of mastication depresses the mandible? It is the lateral pterygoid, okay. So along with the lateral pterygoid, the supraoioid muscle also depresses the mandible, which helps in mastication, okay. That's what it is called as accessory muscle of mastication, okay. So the chewing is by digastric. So one thing is clear. And the other thing is elevation of the larynx is by digastric muscle, okay. All the supraoioid muscle elevates the larynx, okay. So last slide we have seen in the second stage of deglutition, elevation of larynx happens. So swallowing, it is important, okay. So swallowing and chewing is done by the digastric. This is how the digastric helps in swallowing and chewing. It also helps in the speech, but the speech and the swallowing does not happen together. So we can go for option called swallowing and chewing, okay. So the next question, concept of investing layer of the parotid gland. So this is the parotid gland. So the anteriorly you have a ramus and the masseter muscle, posteriorly the mastoid process attached to the sternocleidomastoid. This parotid gland extends over this muscle of masseter, it extends over the masseter muscle also, okay. So and the parotid gland capsule is formed by the investing layer of the deep cervical fascia, okay. Investing layer is the anterior layer of the deep cervical fascia. It splits and encloses two glands, okay. One is the parotid, one is the submandibular gland, and two spaces, suprasternal and supraclavicular space, and the two muscle in the neck called the sternocleidomastoid and the trapezius, okay. So see this fascia, it encloses the parotid gland. It has a superficial layer and the deep layer, okay. The superficial layer attaches to the zygomatic arch, and the deep layer attaches to the tympanic plate unto the styloid process. Okay, and there is a local thickening there which is called a stylomandibular ligament, which separates the parotid gland from the submandibular gland. This superficial layer also extends anteriorly to the masseter. Okay, you could see, right? This parotid gland lies over the masseter. So it extends anteriorly over the masseter or masseteric fascia. So it is called as peritidiomasseteric fascia. Locally, the term here is the peritidiomasseteric fascia. So the important here is, so the peritidiomasseteric fascia is very adherent, and so the parotid swellings are painful swellings. Okay, so the parotid capsule is very adherent to the parotid gland. Okay, look at the next slide, which is also important. I am going to tell you what is SMAS. Okay, you could see the scalp. This image may look complex, but it is simple. Okay, just see, it is scalp. You know what is scalp? Skin, subcutaneous, and gallia is the musculoaponeurotic, and the loose areolar tissue, subgallial fascia, which is the loose areolar tissue, which is the dangerous area, and the pericranium and the skull. Okay, this gallia extends laterally as a temporoparietal fascia. Okay, this temporoparietal fascia is also called as suprazygomatic SMAS. What is SMAS? Is superficial muscular aponeurotic system. Okay, which is called SMAS. Okay, in the face, okay, the SMAS extends till the platysma muscle. Okay, in the face, the SMAS just lies superficial to the peritidiomasseteric fascia. Okay, what is the importance of SMAS? Is the SMAS, like beneath the SMAS only we have a facial nerve. Okay, facial nerve is just lying deep to the SMAS. Okay, so we have a masseter, parotid, covering is the peritidiomasseteric fascia, over that is the SMAS. Okay, in the face, and in the temple region you have a temporoparietal fascia, which is also called as suprazygomatic SMAS. Okay, just beneath that is your temporalis fascia. Okay, what is that? Is a temporalis fascia. Okay, so come to the next question. Which is the following is wrong about mandible? Which is a straightforward question. It is the second bone to ossify. The first is the clavicle. It is the only movable bone. Correct. It contains the insertion site of muscles of mastication. Correct. Okay. It develops purely intramembranous ossification. No. It has an endochondral ossification also, which is happening in the condylar region. Okay. So next question. The nerve supplying the submandibular gland, which is 5th or 7th, we may get confused with 5th or 7th, but they did not ask whether it is a secretomotor or sensory. Okay, sensory is by lingual nerve, secretomotor is by chorda tympani branch of the facial nerve. Okay, so you can choose whatever you can go. So the next question is the adductors of vocal cord. Okay, so in MCQ book it is given as lateral cricoarytenoid, transverse arytenoid, cricothyroid and thyroarytenoid. In textbook it is LOT, lateral cricoarytenoid, oblique arytenoid, transverse arytenoid. Even in SAR's class, SAR is saying LOT, right? Lateral cricoarytenoid, oblique arytenoid, transverse arytenoid. So the password is LOT. So you can go for the option LOT. Okay, so there are two interarytenoid. Okay, this oblique arytenoid and transverse arytenoid or interarytenoids, means it origin and inserts in the arytenoid itself. Okay, so these are considered together. So transverse and oblique arytenoid are important for adducting the vocal cord, means closing the vocal cord. Okay, so the lateral cricoarytenoid also act along with them. So there are two cricoarytenoid, one is lateral, one is posterior. Posterior cricoarytenoid is abductor. The only abductor is posterior cricoarytenoid. This Sarah has repeated n number of times in the class. Posterior cricoarytenoid is abductor. Lateral is adductor. Okay, LOT you can remember, but some of the textbooks they given thyroarytenoid also do adduction. Okay, but you have to importantly remember LOT. Okay. So the next question, which one is called anesthetist artery? Superficial, temporal or facial? So, look at this picture which is given in the recent edition of the textbook. Okay, anesthetist artery, they have mentioned all: facial, superficial, temporal, common carotid. Anesthetist artery means what? Means the anesthetist who usually sit in the head of the patient usually in the head end of the patient during surgery, they will palpate the artery, right? So, but they usually don't palpate the radial artery, they palpate facial artery usually. So, the most commonly palpated is the facial artery. The important point is the antero-inferior angle of the masseter. The facial artery runs at the antero-inferior angle of the masseter. That you have to remember. Most common is facial, but they may palpate the superficial temporal and common carotid also. Okay. So, the last question of this session, the wounds of the scalp bleed continuously because the scalp is highly vascular, blood vessels lie just beneath the skin in the subcutaneous tissue, wounds gape. So, if you cut the gallia, okay, these all statements are true, but if the scalp bleed continuously, it is because of vessel wall fails to retract. Okay, these are the statements true for the scalp, but why the scalp bleed continuously is because of vessel wall fails to retract. Student did not understand the explanation for this question, which is given in the MCQ book. Okay, before going for this explanation, this is the explanation. Before going for the explanation, you have to know how the primary hemostasis happens. It is because of vasoconstriction and platelet plug formation. Vasoconstriction is very important, okay, but the blood vessels in the scalp are embedded in the dense connective tissue, and the walls of the blood vessels are adherent to the fibrous capsule. So, if the vessels are cut, they are unable to retract. That means it is adherent to the fibrous connective tissue. So, if it is cut, what happens? The vessel cannot go for a spasm. If spasm happens, then only the contraction happens. Okay. So, if it is not go for vasospasm, so because it is the walls are attached adherent to the fibrous tissue. Okay. So, if it is not go for a vasospasm, so the vasoconstriction cannot happen. So, it will bleed profusely. Hope, my dear students, all of the doubts for this session is clear. Okay, we'll meet in the next session. Okay, thank you.